it's the at-home kits or whether it's the ability to get the testing that you need. It's cold back home right now, and my hearts go out to those workers who are working in the outdoor drive-in, where they have to go out when it's 20 below, as it is in Fairbanks. That's more of a statement rather than a question there, but I think it is important for folks to realize that we are still in a very difficult place when it comes to accessibility. Dr. Walensky, this is a question for you, and you and I have had many conversations last year about the specific impact of conditional sale orders as it relates to the cruise industry. That industry was effectively shut down for all of 2020, and we were able to salvage a bit of it as things relaxed last year. But in fairness, the industry itself has undertaken extraordinary precautions as one industry to make sure that people are protected from this virus. So the question to you is, I want to make sure that Alaskan communities and businesses can have a season this coming year. And right now, people are making their decisions as to whether or not to book a trip to Alaska for the summer or not. I understand the conditional sale order is set to expire in a few days in recognition that the companies have practices that adhere to or even exceed the guidance in the order. So I guess I'd like some assurance from you that they can count on that this is clear guidance and messaging to those within the industries and to those who are counting on being able to have a season this coming summer.
Yeah, thank you, Senator. And I think the conditional sales order and the fact that the industry has stepped up and is now interested in doing and exceeding, as you know, the compliance with the sale order without the order even necessarily needing to be in place is a real testimony to how well that has worked and how we've worked collaboratively with the industry. What I can say is that, just over the last 2 weeks with Omicron, we've seen a 30-fold increase in cases on ships during this season because of Omicron. So while I anticipate that with ships following conditional sale order, we still will continue to do the oversight and watch and do all the technical assistance and support in every single way. We anticipate that this order will not be renewed and that the cruise ship industries will continue to understand that this is a really safe practice for those industries. What I can't predict is what the summer will bring.
Understand that, but for right now, you expect this guidance to stay in place.
That's my anticipation.
Thank you. Thank you, Madam Chairman.
Thank you. Senator Hickenlooper.
Now it's on. Thank you, Madam Chair, Ranking Member Chair. First, I want to reiterate a little bit about what Senator Romney said. I was the odd one out. I was worked as a scientist for a number of years, and then I was a mayor of a big city and was pretty much the only scientist among all the mayors. Then I was a governor and pretty much the only scientist among governors. And now I'm one of the only scientists among senators. And I recognize from that long list of experience the frustration that you must feel having to put up with the attacks and assaults when you're out there trying to do your job, and something that each of you have committed to is the service of society. Anyway, I just want you to know that I appreciate how difficult science is. It's not perfect, and when you combine that with the complexity of dealing with any large bureaucracy, I'm not making apologies. These are just like, just like any, well, we're having a war against this virus, and just like in any wartime situation, mistakes have serious consequences. But I appreciate more than I can say how much work you all have done, and I don't think anyone here thinks you're not trying your very best all the time. Really appreciate that. Dr. Fauci, I think one of the problems we haven't gotten far enough on is innovation, and how do we stimulate innovation to go faster and better? How do we increase the not just the breadth of our vaccines, but the durability, so that as we get the next wave, I'm not sure how many letters there are in the Greek alphabet, but I know there's going to be another one. And in that process, because I think this country is known for innovation, it is one of the tools that we have that we know will work. I'm hoping that you can take the opportunity to be a little bit optimistic and feel that you're not going to be judged and held accountable, because I think people want to hear that we are going to come through and begin to look at some of these things successfully.
Yeah. Well, thank you very much, Senator, for your original kind comments, and I'll answer your question now. As you know, as a scientist, that there are fundamental basic issues that are discovery, that once you get the discovery, then you could do the implementation of that discovery. We were very fortunate in that the basic research and clinical research investments that had been made literally for decades prior to the new revelation that we had a very threatening virus among us was the reason why we were able to use new platform technologies as well as immunogen design to get highly successful and safe vaccines. That same thing is going on right now. It isn't well known because it isn't front page yet. And you know, as a scientist, when you're doing your basic research, it's only until you get the result that people really understand what you've been doing. There's a lot of investment, not only in improving the vaccines that we have for COVID, for SARS-CoV-2, but a lot of work, as I mentioned in my opening statement, about looking at using the tools of fundamental, basic, and applied science to develop next generation of vaccines, particularly universal coronavirus vaccines, or at least universal SARS-CoV-2 vaccines, so we won't be chasing after the next variant, that we'll be able to have a vaccine that has the capability of responding to every iteration of a variant. And there's a lot of work going on with that right now. But again, when you're doing basic research, as you can appreciate as well or more than anyone, that usually isn't very well recognized by the public.
Point made. In terms of testing, and a parallel thought, Dr. Woodcock, maybe you can address this. The testing now is, by the time it gets to the retail, is somewhere in the $15 to $20 range, maybe as high as $22 or $23 in some places. Is there the prospect of, because I keep reading about different approaches to testing, that we might find a way to reduce the cost of testing down to, instead of $15 could be 15 cents, or at least for the chemical side of it. I realize then you've got to manufacture it and put it in cases and, packaging. Maybe you can provide a little optimism on that.
Sure. Well, I believe the RADx program, which Congress provided funding for quite some time ago, is really cutting edge, and they have a sort of a Shark Tank approach. They're really looking for innovation. They provide assistance to developers, and I really believe that's promising, that we will come up with additional technologies. They're easier to manufacture and actually easier for people to use and cheaper.
Great, thank you. And I have obviously more questions, but I'll yield the floor back.
Thank you.
For now.
Senator Braun.
Thank you, Madam Chair. Reading the paper last night, a lead editorial in the Washington Post, and I about dropped it when I read the first paragraph. And the title of the editorial is "Living with COVID." Quite understandably, the coronavirus pandemic at first was a dire emergency, but it can't be one forever. The crisis will have to shift to a manageable health threat without massive disruption and overwhelming anxiety. President Biden has been fighting the virus as an emergency in his first year, but a shift must come before too long. Never thought I'd read anything like that in a place like Washington Post, but I think it reflects where we're at in the journey. And generally, when you wrestle with something of this magnitude, where it's dominated the conversation for now 2 years, and you're still seeing results similar to, if not worse, from when we started, it would beg the question, do we need to take a different approach? It's been very top-down, been put in place, I think, understandably by the agencies that would be most pertinent. But when you look at the results, you look at the fact that a third of the country, for whatever reason, is not going to get vaccinated. You got a mandate that now is going to force the hand. And when you get someplace like the Washington Post saying that we got to take a different approach, I'm wondering, do we have it within our Constitution here when we've been bought in for so long that this is the way it's got to be? Listen to Senator Casey earlier, made a very good point. Everybody talks about data, paying attention to the data. And when this is so ravaged, such a small percentage, so significantly of our population with comorbidities that are elderly, it just keeps saying, why don't we change the approach? You don't want to have the legacy of being a country in disruption and full of anxiety. And kind of what I'm hearing here today, I'm not sensing that we're going to see a real change in approach, and even more so, doubling down on what now for 2 years has arguably not gotten us in a place where we feel better about it, where we're not drowning in anxiety. And I'm going to pose the question to Dr. Woodcock. You've been involved in federal health care in one way or another for a long time, acting commissioner at the FDA. Normally, a board of directors, a CEO, would be fired as a CEO, number one. A board of directors would be questioned in terms of how good they are, meaning maybe us here in the Senate, to where you're not directing for something other than what we've had, which in my opinion would be decentralizing it, providing the information to the American public to make their own best decisions. Dr. Woodcock, do you think that is sensible? Do you think the Washington Post makes sense? And are you willing to change up there on this panel to reflect accordingly?
Well, I think that we're talking about a natural disaster, and you can fire your board of directors because your factory was devastated by a hurricane, a tornado, or a wildfire, but I don't know whether that would improve the situation. I think right now we need to focus on continuity of operations for hospitals and other essential services as this variant sweeps through the population. I don't think that will last a really long time. But that's where I think we are right now. So I don't think prior, approaches reflect what's going on right now. I think it's hard to process what's actually happening right now, which is most people are going to get COVID. All right, and what we need to do is make sure the hospitals can still function, transportation, other essential services are not disrupted while this happens. I think after that will be a good time to reassess how we're approaching this pandemic.
I'm out of time, but I think if you want to regain the trust of the American public, you probably need to look at a total revamp on what we do in terms of how we contend with it over the next year or so, or I think you're going to get more forceful editorials from places that you would never imagine. If you keep doing the same thing, generating the same results, that isn't the formula for success in any endeavor.
Thank you. Senator Baldwin.
Thank you, Madam Chair. I want to thank all of our witnesses today. And I also want to just underscore the preface that our colleague Senator Romney gave to his his questioning. I like the way he described it. Sometimes we come to perform, sometimes we come to be informed. And I guess I would just speculate a little bit beyond that. If there were to be a true tit for tat on the performance angle, there's any number of areas we could go. I reflect on proposals for ultraviolet light and drinking bleach and drinking hydroxychloroquine. We could go there, but it's not constructive. And so I'm going to be constructive in my questions, and I just urge my colleagues to do that. We're all in this together, and we have a duty to act responsibly in that fashion. And again, thank you to our witnesses. Dr. Walensky, I'm going to start with you on a topic that I bring up frequently when you're in our presence, and that is the tools we have now to sequence, do genomic sequences, to better understand variants, to better track variants. I know that there's been much investment in that. I'd like to hear what tools that we have in place now that we didn't before, and what you see the future of this genomic sequencing is, especially as this committee looks at pandemic preparation for future potential pandemics.
Thank you, Senator Baldwin, and for your championing our ability to ramp up our genomic sequencing efforts, and the resources from the American Rescue Plan, $1.7 billion, really did allow us to detect Omicron swiftly. So maybe I'll just tell you the story of what happened with Omicron, and that is we heard about this variant that was coming from South Africa, and we didn't know if it was here yet. But we did know it had this unique footprint of the S gene target failure on PCR. So what we did immediately after hearing about this is do enhanced surveillance for this footprint and do enhanced sequencing so that any sequence that had this footprint, I shouldn't say any, many sequences that had this footprint, we were specifically looking for this Omicron variant. Within days, we found it. So within 3 days, I think, that we started doing this enhanced surveillance, and then within days, we had, 10s, 40s. By about 4 days later, by December 5th is when we started detecting it in our background genomic sequencing. So that background genomic sequencing now does tens of thousands of sequences a week. It's a collaboration with academic partners, industry, commercial labs, CDC labs, public health partners to do tens of thousands of sequences a week. And what we do is we look at the number of cases that are out there, and our goal is to detect a variant that is present at 0.1% with 99% confidence, so that we see the menu of variants that are out there. We are enthusiastic about this program. We are intending to ramp up this program for potentially other viruses, the potential to do so there, for other foodborne outbreaks, as well as for wastewater investigation. We have the capacity to do that there as well. So again, thank you for championing this effort, which truly did allow us to detect Omicron in real record speed. Thank you.
Thank you. Next, Assistant Secretary O'Connell, when we last met at this committee, I asked you for a commitment that a significant portion of the $10 billion for the Defense Production Act funding that I helped secure as part of the American Rescue Plan be invested in the raw materials needed to make N95 masks here in America. The alarming spread of Omicron has made the need for N95s even more clear. And yet, ASPR has not spent any of this American Rescue Plan funding on the raw material needed to make N95s in America, while it has invested $3.1 billion on other priorities, primarily using prior supplemental funding. The FDA reports now that 60% of the KN95 masks that are being imported from China are fake, and Americans still can't go to a local pharmacy and purchase an American-made N95. So President Biden has now personally urged Americans to upgrade the quality of the masks they wear. I want to know when the American people will be able to buy an American-made N95 mask that they know will protect them, and when we can expect ASPR to invest the American Rescue Plan funding into the raw materials necessary.
Senator Baldwin, thank you for that question. You can buy an N95 mask manufactured in America now. We have 737 million of those in the Strategic National Stockpile. We are also in the process this month, we hope, to award, or next month, as contracts go, to award an agreement for warm base manufacturing of N95 masks. What we're asking the vendors to return to us as part of the proposal is their ability to manufacture 141 million masks a month at a surge capacity, and to be able to maintain that manufacturing at a 20 to 30% rate in times where demand is not as high. So we are very invested in N95 masks being made available, and we'll continue to look, and I appreciate your support in getting us the American Rescue Plan dollars that we're currently investing, and we'll continue to look at the right ways to invest that, and have really appreciated the conversations you and I have had around that.
Thank you very much. I appreciate the witnesses have been here well over 2.5 hours. We are going to have a second round of questions. So I'm going to recess for 10 minutes to allow a break for our witnesses. We will reconvene at 12:45. going to be very strict with the 5-minute rule, as we have moved way past our time here and we need to move on. So with that, I look forward to the next round of questions so we can get to the essential work of addressing this pandemic, which has upended so many lives and that continues to threaten the public health. And we will begin with Senator Baldwin.
Thank you, Madam Chair. Dr. Walensky, during our last hearing, we discussed the critical need for my Biopreparedness Workforce Act legislation that I introduced with Senators Collin, Rose, and Murkowski to strengthen our outbreak response workforce so that we can better prepare for the next pandemic. This legislation would address the serious workforce shortages and recruitment challenges that you mentioned by establishing a new loan repayment program focused on encouraging students to pursue careers as clinicians and biopreparedness health professionals. As this committee assembles a package of policies to respond to the next pandemic, it's important to remember that without people, there is no preparedness. In the midst of the Omicron surge, it has never been clearer that we need a robust and capable workforce to fully respond to public health emergencies. The Biopreparedness Workforce Act would go a long way towards that goal. So Dr. Walensky, as an infectious disease physician and public health leader, can you share more about how a strong clinical and public health workforce is key to responding to outbreaks and how legislation like the Biopreparedness Workforce Act is important to prepare for the future, public health emergencies?
Yes, thank you, Senator. There's so much here. So first, let me just say, there's been a recent study that has demonstrated that our public health workforce is now down about 80,000 jobs. So just to give you a sense, and that's public health workforce, that's not physicians who are actually doing the work on the ground, right, in the hospitals. This is a public health workforce down 80,000 jobs. We saw through this pandemic the challenges in sort of the volume of people who were doing public health work, but also where they were located and their experience. We need an upskilled public health workforce. For example, we need people to do those genomic sequences. We need genomic epidemiologists. We need people who are diverse as the communities they serve. We also need to make sure that they are compensated, have the right salaries, and as you say, have loan repayment for their work. To give folks a sense, the infectious disease physicians are among the lowest paying physicians in hospitals. They don't do procedures, and by virtue of not doing procedures, there's not a large incentive from a financial standpoint to continue to go into infectious diseases, which are the bread and butter of what outbreak investigation and clinical it does. So there have been many resources that we're moving forward to expand our public health workforce. Public Health AmeriCorps is a big piece of that, and that is something that we're working on and really grateful to resources from Congress to be able to do so. But there's a vital need now to expand our public health workforce in laboratory capacity, in genomic surveillance, in disease outbreak investigation, and a workforce that is upskilled and as diverse as the communities we serve. Thank you.
Thank you. We all know that vaccines remain the best way to protect yourself against existing variants of COVID-19. And I've been encouraged by the FDA's work to authorize vaccines for the public, but parents continue to be concerned that we don't have a vaccine for their kids as Omicron surges. Dr. Woodcock, can you provide an update on where we are in examination of the authorization of COVID-19 vaccines for children under 5?
Certainly. As Dr. Fauci said earlier, they were one of the companies, Pfizer, had done trials. There were other trials going on. There were probably complications with the dose in the slightly older of the younger children, perhaps indicating that a third dose, as Dr. Fauci said, might be needed to the primary regimen. FDA is working with the company very closely. Trials are ongoing. I, too, have heard from many, many parents of the youngest children. They have other children in school. They may have immunocompromised individuals in their household, and they're people who really want to get this vaccine. So, one of the vaccines, and get the children vaccinated. So we are working very intensely on this right now, and we're working, of course, with NIH and with the companies.
Thank you. I yield back.
Thank you. Senator Paul.
Dr. Fauci, it's disappointing for you to suggest that people who dare to question you are responsible somehow for violent threats. Realize that by attacking me, you're attacking the one member who actually has suffered from violent attacks. I was at the ball field today. Steve Scalise almost died. I was 10 feet away from a staffer who was shot in the leg. We had over 160 rounds of semi-automatic weapons fired at us, ammunition. So for you to somehow suggest that somehow I or people who dare to oppose you are responsible for threats, that's insulting. The person who shot at us and almost killed Steve Scalise was a rabid supporter of Bernie Sanders. But the one thing you'll find if you look at the record is that not one of us accused Bernie Sanders of being responsible for that. So this is the kind of ignorant sort of personal attacks that you've engaged in. You engaged in these attacks with fellow scientists. Not only was it 3 scientists from Harvard, Oxford, and Stanford that you chose to malign, 50,000 scientists and medical doctors signed this petition. And what they wanted was something that most Americans think is pretty reasonable. It's a different kind of approach. Instead of saying that everyone is the same and everyone should get the same treatment and everybody ought to just get vaccinated, what it did is it said that the death rate for this disease is extraordinary in the risk being different according to ages. So if you look at an 80-year-old, it's at least 1,000 times greater death rate than it is for a 10-year-old. So wouldn't we want to say that, well, we're going to assess the risks of each individual and have the treatment according to that, or would we just simply say everyone should be vaccinated? The death rate for kids under 18 is about 1 in a million, a little bit less than the chance of being struck by lightning. We don't yet know fully whether or not kids who have already had COVID might be at risk for some of the side effects of the vaccine. Still needs to be explored. But for a kid under 18 who's already had COVID, see, it's death rate of about 1 in a million, even if you haven't had a disease, even if you haven't had COVID, it's about 1 in a million. It's extraordinarily uncommon for a child to die. If you've already had the disease, it's probably a great deal less than that. Many Americans wonder why you've steadfastly refused and worked with others to try to hide any kind of knowledge of natural immunity and how it would affect our decision making. So for example, you have a 10-year-old kid and his mom comes up and all of a sudden he gets myocarditis from the vaccine and dies. Admittedly a rare complication, but what are you going to tell her when she says, well, he had COVID 3 months ago. I mean, why would you force me to vaccinate my kid? Why would you force me to vaccinate my kid without even checking to see whether he's already immune? Now, the idea of natural immunity is the idea upon which vaccines are based. We've believed, and all of medicine is based on the idea of acquiring natural immunity. People often respond and say, but you don't know how long it'll last. Well, we don't know how long vaccines will last either, and that doesn't make us anti-vaccine. We do know that the vaccines are waning very quickly in potency. We do know that the vaccine against Omicron really isn't preventing transmission. You've noticed that the debate has shifted, and the debate is now talking about trying to prevent hospitalizations and death. And I agree with those statistics. I think it's a good idea if you're at risk to be vaccinated. I've always been pro-vaccine. I'm just simply against authoritarianism and against mandates. Right. The anger that's developed with you, Dr. Fauci, is that you don't want to give us advice. You want to tell us what to do. You think you are the science, and that anybody responds to you, how dare you? How dare you criticize science? As if you somehow are science. That kind of arrogance, that hubris is really, that's where the anger is coming towards you. If you were one doctor among hundreds of doctors in the government who gave advice, I don't think people might object to your advice, but there wouldn't be such a degree of anger. But you are so certain that you're right that you're not willing to hear anyone else. 3 epidemiologists, of which you are not even an epidemiologist, but 3 epidemiologists prominent in their field, Oxford, Stanford, and Harvard, you maligned them. You spoke openly with Dr. Collins, and you did not disagree that let's paint them as fringe. You went after them and said, we will do a public takedown, not in Science or Nature or Lancet, in Wired, in The Nation, a left-wing publication. You've engaged in base politics. You wonder why there's so much anger? You're not an objective scientist. You've lost that long ago. And so many of the things that people want, it's like they want to know why you're forcing their children to be vaccinated when 95% of people at risk have been vaccinated. Over 95% of people over 65. It's a huge voluntary success. And yet you won't rest until you force every child to get this. So yes, there's a great
Senator
deal
Paul,
of
your time has
dissatisfaction with
expired.
you, and many people want you to go, but nobody wishes you violence.
Senator Paul, your time has expired. I will use one time of my remaining 5 minutes to allow Senator Fauci to respond.
Thank you very much.
Dr.
Madam-
Fauci, sorry.
Yeah. Thank you, Dr. Murray.
No.
So, first of all, Senator, again, at a hearing such as this, where there are almost 900,000 people in this country have died from this outbreak, you have chosen to just personal attacks on me that go back to multiple hearings. And again, just for the record for people to check, I have never said take people down in that email. It was an email that was sent to me. See, and again,
You agreed with Dr. Collins in the email.
Senator Paul, this is my time.
you know, you personally attack me, and the things that you do are incorrect and proven incorrect. You've publicly accused me at a hearing of being responsible for the death of 5 million people, when there is not a single shred of evidence that anything that was done with the NIH had anything to do with COVID-19. You talk about things like gain of function.
Dr. Fauci, I'm going to let you respond continually, but I think you have responded, and I appreciate
Okay, I
your
appreciate the
response
time. Thank you very much, Madam Chair, but I just want to say, I'm actually stunned by the amount of misinformation. The only thing I have ever done, and this will take 20 seconds, if you look at the things I've said, they've been to support the recommendations of the CDC, of their advisory committees, and of the FDA. I've told people that it's important to get vaccinated, to get boosted, to wear a mask, and to be prudent. That's the only thing I've said. I haven't dictated anything that's only a monolith with me. It's always public health practices. And anybody goes back over any record of
Dr.
me,
Fauci,
they know that.
Thank you, and I will retain the balance of my time. Thank you very much. Senator Casey.
Thank you, Chair Murray. I want to start with Dr. Walensky. Doctor, as you know, the CDC has been working with my staff on an outstanding nursing home vaccine data request. I would appreciate it if you and your team would continue to work with me and with our team at the Aging Committee to resolve this matter.
Yes, thank you, Senator. I'm aware of that matter, and we are committed to continuing to that work with you. Thank you.
Thank you. Let me turn to a matter for Health and Human Services. Assistant Secretary O'Connell, you know that our nation's long-term care facilities were ground zero during the first year of COVID-19. 200,000 residents and workers, when we add up the number of residents plus the number of workers who died, it gets to 200,000 over these 2 years. However, nursing home deaths have declined dramatically thanks to the safety and effectiveness of the vaccines. It's a credit to the administration that 90% of nursing home residents and 80% of workers have been vaccinated. We know that infections are on the rise right now, though, in nursing homes, raising safety concerns and putting additional pressures on workers who have been stretched thin. For instance, we know the pandemic has worsened existing staffing shortages and turnover issues. So we also know at the same time that the rescue plan that Democrats passed in March helps to fill the staffing gap with a $500 million initiative for strike teams based upon legislation that I was leading recently. These strike teams provide medical personnel and other supports that help nursing homes get through the surges like the one that we're seeing right now. On the 22nd of December of last year, I, along with 3 of my colleagues, sent a letter to Secretary Becerra asking how Health and Human Services was protecting nursing home residents and workers in the current COVID-19 surge, including the distribution of booster shots. What is HHS doing to ensure nursing homes have the supports they need to protect residents and workers who care for those residents?
Senator Casey, thank you so much for your question. We share your concern for nursing home staff and long-term care facility residents and have continued to do all we can to make sure they have access to boosts. We've worked with pharmacies to bring in vaccination clinics, bring those to the long-term care facilities and skilled nursing facilities. So the vaccines are available on the ground and the residents don't have to travel or access the vaccines on their own. In addition, ASPR has been sending since the beginning of the pandemic or since the beginning that these tests were available, 2.8 million tests per week to long-term care facilities across the country. We know how important it is that they're able to surveil any disease in their facilities, and having access to these tests is one of the ways they can stay on top of where they are. So we share your concern, and we'll look forward to responding to your letter.
Thanks very much.
Senator Burr.
Thank you, Madam Chairman. Ms. Woodcock, I know you said a while ago that you're excited about what RADx accomplished, and I think we all are. But FDA issued revised guidance stating that it would focus its review efforts on at-home test and point-of-care COVID test applications from developers with the capacity to manufacture more than 500,000 tests per week within 3 months of being authorized. Why did the FDA move the goalpost at this particular time and suggest to companies that can't ramp up to that manufacturing that they're not going to get an accelerated EUA pathway?
Well, because of what some of the members have been discussing over the last several hours, that we have an urgent need for high volume home-based tests. And we have a queue. We have moved heaven and earth to get as many done as possible. We've authorized over 400 different kinds of tests or test collection devices during this pandemic. But as far as what the queue is, the priority, we're prioritizing the highest volume and just putting them to the front so that we can get home test kits into the hands of
Woodcock,
people.
I get what you're doing.
Yeah.
My question is this. What does this say to the innovative company that's out there that doesn't have the manufacturing capacity, and without us marrying them to a large manufacturing capacity, it's basically saying don't innovate because you're not going to get consideration under the EUA if you don't have a manufacturing capacity of 500,000 tests a week.
It says these are prioritized. It doesn't say we won't get to the others.
Well, get to the others. I mean, there's all a sense of urgency here. I just think that that might have been thought of before we did this. Let me go to you, Ms. Connell. I'm really challenged on this procurement of 500 million tests, as you can tell. And one, I don't understand why there's not been a release that came out of ASPR or Barta publicly announcing here's how many we've contracted, that I've got to find it somewhere in a DOD contract that a very limited amount of people go to. It's certainly not one that I regularly looked at. But based on one of your contracts, we've got 13.6 million tests costing $190 million. I think that's from the vodka distributor. Mm-hmm. When I break that down, that's about $14 a test. Now, CMS just put out a new rule that mandated that insurers must cover up to 8 tests per person per week, per month. For a family of 4, that's 32 tests, and that they can reimburse at $12. Now, if I'm a manufacturer and I'm under a $12 reimbursement, or I can go over here and I can sell directly to the federal government and get $14, I'm probably going to sell to the federal government and get $14. Where am I wrong?
Thank you, Senator Burr. We continue to work to access the tests that will be distributed as part of the 500 million and the tests that you're referring to. So first of all, DOD by tradition has put out, whenever we've done an assisted acquisitions with them, they put out within the first 24 hours of that contract going out an announcement that the contract has gone out. So that's what you're seeing, and that's been de rigueur. It's been what the way DOD has approached this through our entire relationship. We're continuing to.
Why is Asper not putting out a similar public statement?
We'd be happy to, and thank you, Senator. I'll go back and talk to the communications team and see if there's a companion press release that makes sense for us to put out.
Well, I'm not sure you addressed my concern, which is it's more profitable to sell to the federal government than it is to put it on retail based upon the reimbursements that this administration has now required of insurers. I hope you'll think about that. This is alarming to me, and as we've all displayed, there are no tests out there. There are no tests on the shelves at Walgreens, CVS that people can go in, buy, and take home and do it. So it makes even more confusing CDC's policy that if you want to take a test, go ahead and take it. It's not required, but you can take it. You can't get it. Dr. Fauci, just very quickly, South African data suggests that Omicron may have an ability to build immunity to Delta. Delta does not have an immunity to, it does not build an immunity to Omicron. Have you got any comments on that? Cyprus announced a Delta Crom variant. Are you worried about that? And we've been about 3 weeks behind Israel throughout this whole thing. And even though we've seen South African data go up and go back down very quickly, Israel epidemiologists just this week said they expect that for the next 2 weeks they will see a doubling of the infections in Israel, meaning they're not following the same timeline that we saw in South Africa. How should we interpret that for the U.S.?
Okay, thank you very much for those questions, Senator. With regard to the cross protection, I think it's too early to tell because you're dealing with multiple population demography of people who've been previously infected, vaccinated, or what have you. It seems pretty clear that if you get infected with Omicron, you're going to get good protection against Omicron, but also good protection against some of the other spillovers. So we really yet to have seen, and I think the basis of your question is a reasonable one, if we wind up getting infected with Omicron at a very, very low level of pathogenicity, is that going to be sort of almost like a live attenuated vaccine? I don't think we can say that right now. We really have to see how things spread out when we see how that fares in the next variant. So there will be invariably another variant. We're going to have to take a look at whether or not there's going to be any protection there. That's the first thing. With regard to the Delta Cron, this new variant, right now, even though it's got, a bunch of mutations that people look at, it is not something that at least the WHO, who's looked at this carefully, feels that has to be something that is of great concern. But we always keep our eye on it to make sure. So when you say it's not of a great concern now, the one encouraging thing about it is that it's been around for a while. It isn't something that just propped up. And yet Omicron completely outstripped it, as did Delta. So it doesn't look like it has the capability of being transmissible enough to be a problem. Nonetheless, we still keep an eye out on it. With regard to Israel, I'm not sure, I'm sorry, I forgot your question about Israel. Could you repeat it?
And we are way over time here.
They run about 3 weeks in front of us.
Yeah.
Yet their experience is not up and down drastically like South Africa data begins to show. They went up, and now it looks like over the next 2 weeks, their epidemiologists say it's going to double and maybe double again before they hope it comes down. What should we expect?
Yeah, I think that's a great question, Senator. But what it really reflects is that when you have an outbreak of a particular variant, how high it goes up, when it peaks and comes down is a reflection of what the status is in your country. Because if you look at what you saw in South Africa, they were almost free of Delta when they got Omicron. So Omicron sort of had the unfettered capability of going way up and way down. When you talk about what happened in Israel, that's a different population. It's a mostly vaccinated population, so they're likely going to see breakthrough infections. In the United States, we have such a large country with such differences in vaccinations versus infections, et cetera, that we believe we will see it peak and we will see it come down. But it's very difficult to predict whether it's going to be a sharp decrease or whether it's going to do this. Our own feeling, and I believe that Dr. Walensky feels the same way as I do, that it's going to vary depending upon where in the country you are, how much infection you had previously, what the level of vaccination is. So we may see a peak up and down in some regions of the country and a peak up and doing this in other regions of the country. Thank you.
Thank you very much. Senator Smith.
Thank you, Madam Chair. I'd like to ask a question of Dr. Walensky, if I could. I think we all know that Americans need better access to rapid testing, and this is a big deal for us in terms of trying to figure out what are our health risks, how do we protect ourselves, and how do we also go about our lives. And I think that we are making headway here, that we have a long way to go. Dr. Walensky, I'd like you to talk about this issue of how we should be or not collecting and analyzing the data from rapid home tests. Should we be incorporating this data into, should we try to capture that data? Is this important for local communities as they're trying to make decisions about masking and other public health strategies that they want to deploy? Should we be thinking of the data from rapid tests as a tool for individual risk assessment or as an important tool for population level understanding of what's happening? How do you see that?
Yeah, thank you so much, Senator Smith. So we have been using the PCR test, not the rapid tests, the lab tests, the molecular tests, to really capture our case counts and really get a good view of where we are in terms of the epidemiology, anticipating what was going to be coming into the hospitals. But the self-tests are a really important, valuable tool for people to empower themselves, their own health, to not expose themselves to other people, to get some information about their own health. And so if an individual were to test positive, if they're feeling unwell, they should certainly consult with a healthcare provider, consult with a pharmacist and your health department. But if you're feeling well, then use that rapid test to say, okay, my test was positive, I need to stay home and isolate, protect myself from the community, protect myself, or the community from me, and protect me, my loved ones, so that they don't get infected themselves. And I think that it's less about the absolute case count of understanding whether you have asymptomatic infection or a runny nose and your rapid test is positive than it is really about empowering you to do the right thing and not be forward transmitting.
Could you talk a little bit about what other countries are doing? Are other countries in trying to incorporate this rapid testing data into their population metrics? How is that working in other places around the world?
Some countries are and some countries aren't. London and UK have been doing more reporting of rapid testing, but they too are saying that they're missing, I think, somewhere around 40%. I'd have to confirm that number, but they too, while they capture more than we have tried to, they also agree that they're missing some as well.
Okay, thank you very much. Madam Chair, I'm going to cede back the rest of my time. I just want to acknowledge something I think has been going on here today that I think just deserves being called out. Dr. Fauci has been the target of a concerted and coordinated campaign of disinformation and distortion and personal attacks. And then he's being blamed for all of this hatred and anger that has been generated against him. And I mean, I think we just need to be honest here that this is being done by some members of the Republican Party that are using it for fundraising. I'm not saying that that's happening by members of this, I'm just saying that that's happening. I was just pointed out to me that somebody sent out earlier in 2021, a Fauci for prison email. So I just think it's important that I have to call this out. And I think it's important that we see it, and we have to try to rise above this kind of behavior. Our committee here should be focusing on these kinds of nitty-gritty policy questions, and we're not always going to agree. I've never heard Dr. Fauci or Dr. Walensky, for that matter, declare themselves to be invincible. I certainly am not. But that should not mean that individuals, career public servants, are subjected to this kind of abuse. Thank you, Madam Chair.
Thank you. Senator Collins.
Ms. O'Connell, I want to follow up on my previous questions to you because I don't feel, frankly, that I got answers. I'm asking you specifically how much money was diverted from the testing budget to deal with the surge of people, including unaccompanied minors, illegally crossing the southern border? And how much money was diverted out of the funds allocated for the strategic stockpile?
Thank you, Senator Collins. Again, all of the funds as they were appropriated to the American Rescue Plan for testing, contact tracing, and mitigation efforts. Of those funds were used to test unaccompanied children at the border and then to mitigate the COVID positive cases so they wouldn't enter the community and spread COVID, which was a use of the funds that was allowed under the testing, contact tracing, and mitigation requirements.
Well, you're still not answering my question on the amount of money that was used to deal with the crisis at the southern border. So I will tell you that our staff's investigation found that $850 million out of the testing budget and another $850 million out of the allocation for the stockpile were instead used to deal with the crisis at the southern border. Do those numbers sound right to you?
Senator, I'll be happy to take that back and discuss that with our finance team to make sure that those numbers are the same numbers that they're tracking.
Well, I have to say that it's interesting to me that you knew all of the numbers, and I commend you for this, that were going to community programs, to schools, et cetera, but you can't tell me how much was reallocated to deal with the crisis at the southern border, a crisis that, were it brought under control, we would have these funds for the purposes that they were intended. Let me ask you further, what do you mean when you say mitigation as applied to the southern border and the surge, the unprecedented surge of people crossing?
Thank you. One of the important things that we needed to do when we identified a COVID positive unaccompanied child was to make sure, for example, they didn't ride on the same bus to a shelter with a COVID negative child. So there were additional costs for transportation to keep the children separate to mitigate spread, as the statute allowed us to spend those funds. In addition, within the shelters, it was necessary to set up a separate room where COVID positive unaccompanied children would reside so they wouldn't interact with the COVID negative children, and that required additional resources in those shelters in order to keep them separate. So when the children entered the community with their sponsors, they were not bringing COVID into the communities.
Well, I will tell you, having visited the southern border in late March, testing was being done, but people had been there for weeks at a time with no testing. And there were people, adults, who were released into the community with no testing. The fact it remains that if we had the southern border under control, we would be using the $850 million designated for testing to buy more rapid tests. We would be using the money out of the stockpile, the $850 million, for the purposes for which it was intended. So I think that this is a problem that has contributed to the shortage of testing, the uncontrolled crisis at the border. And I also am perplexed by the lack of federal orders for tests between January and September of 2021, which I know from my experience in Maine caused a major manufacturer, Abbott, to lay off 400 workers that were producing those tests because it lacked the federal orders. That makes no sense to me and seems very short-sighted. Thank you.
Thank you, Senator. Senator Hickenlooper.
Great. Thank you, Madam Chair. And again, thank each of you for your public service. Dr. Walensky, I wanted to talk to you just for a moment about genomic sequencing. Even before COVID-19 appeared, Colorado made a genomic sequencing of diseases a high priority, and we're now, I think, one of the leading states in detecting changes as they evolve in COVID-19. We test about 15% of all positive COVID tests. I think that's still one of the highest rates in the country. And we also monitor wastewater for community detection. So, Dr. Walensky, how would we, or how can we expand genomics surveillance and expand those capabilities in order to try to stay ahead of existing but also future threats, COVID-19 or otherwise? How do we close the gap between, the states that are heavily sequencing and following this and those that aren't?
Yes, thank you for that and for your leadership in Colorado in genomic sequencing. As I've mentioned, we need to have both numbers and breadth and geographic distribution in order to get a real good view of what's happening in genomic sequencing. So we need to sample from state labs, so we get samples from every single lab. We also get samples from commercial labs, which gives us a lot of volume. We have partnerships now with 19, I believe, academic medical centers in order to do so. And what we do and power our genomic sequencing is so that we are able to detect a sequence that's present at less than 0.1%. So we scale up, and based on the number of cases that we have, we scale up or scale down our genomic sequencing so we can detect it. And what we were able to do with Omicron is when we saw the footprint of the S gene target failure in PCRs, a similar footprint as alpha, we were able to do targeted enhanced surveillance of sequences that actually had that initial footprint and able to identify sequences even before they reached that 0.1% threshold. So as you said, we can scale this up in wastewater. We're able to potentially scale it up for purposes of antimicrobial resistance, for foodborne outbreaks and many other things, which we're really looking forward to doing now that we've established this incredible capacity.
Right, great, that's perfect. Ms. O'Connell, I want to ask you a question in terms of we've talked a lot about the distribution of tests and whether it's schools or workplaces, hospitals. And we've talked about how at this moment we don't have enough tests out there and we're not getting results quickly enough. In terms of the distribution of tests on a national level, we're still obviously working on a system. I know the administration is hard at work on this. But some states like Colorado already have systems in place where tests are being mailed directly to people in their home. And I guess I don't know, is the federal government working with states like Colorado and trying to look at those systems already in place, and how do we integrate the federal system with those states?
Absolutely. Thank you, Senator. That's terrific what Colorado is doing. We have invested $29 billion with the state so they could set up such testing programs however they saw fit. And we are seeing states like Colorado use those funds to be able to do exactly what we're hoping to do on a national level. We are in the process, as we've talked about today, setting this up, working with the U.S. Postal Service. As the federal government, we will allow American households to order and have them delivered to their house as well. I imagine that these will be in addition to what Colorado is able to provide. And we want to have as many tests, of course, available to all Americans as possible. So if Colorado's already doing it, that's terrific. I'm sure we will learn some lessons from the experiences you've had in your state and apply those to this national initiative.
Great. Thank you on that. And then just real quickly, Dr. Fauci, we've heard from Dr. Walensky was just talking about how you integrate the aggregation of large amounts of data. And we've had a discussion about Israel versus South Africa. And it really is a question of how do we take, my question is how do we take information from global sources and learn from those countries who are ahead of us on the curve, make sure that we're learning from their experiences. And I think how can we do a better job working with our international partners to make sure that we are prepared for the next Greek letter?
Yeah, well, thank you very much. Excellent question, and we are just actually doing that. Every week to 10 days, I have a long phone call with Chris Whitty and Patrick Valens, who are the two leading medical and scientific advisors to the Prime Minister of England, to get a feel what's going on there. We have regular phone calls with our Israeli colleagues, and every Saturday or Sunday morning, depending upon what it is, Dr. Walensky and I and others are on the phone with our South African colleagues. So we are in literally constant communication with them.
Great. Thank you.
Thank
Yield
you.
back.
Senator Marshall?
The American people, my family, all of our families are struggling as this pandemic continues to drag on with no end in sight. The words I hear every day, multiple times each day, continue to resonate and echo in my mind as I sit here. Words like I'm tired, confused, burnout, scared, and frustrated. The list goes on. But what's making the situation worse are the officials leading our nation's COVID response going on national television and contradicting each other. And of course, some Supreme Court justices are spreading misinformation as well. Dr. Walensky, this past week, you recommended asymptomatic people be able to return to work after 5 days. But Dr. Fauci ambiguously corrected you on national television and suggested folks needed a test before return. How does that make you feel when Dr. Fauci or someone like Justice Sotomayor upstages a previous statement or policies of yours, blatantly contradicts and undermines your guidance, or offers false claims that cause more confusion for the American people?
Thank you, Senator. I have the great honor of leading the agency of 12,000 public health servants in this country, and we work collaboratively with tens of thousands of public health officials around the country to provide guidance. I also get to work with a COVID-19 task force that is full of a multidisciplinary group of people with diverse expertise, from immunology to drug regulation to epidemiology. This science is moving really quickly, and I know you will appreciate that it's moving fast and it is changing, and it is our
you're not answering my
responsibility
question,
to convey that science.
So I'll move on. The FDA has recently set up protocols for monoclonal antibodies and antiviral pharmaceuticals to be prioritized based upon race. Dr. Woodcock, has the CDC or FDA done a multiple regression analysis on race to see if indeed it's an independent factor for increased morbidity and mortality? And if it hasn't, don't you think zip code would actually be more predictive? Wouldn't it make sense to prioritize these antivirals and testing, for that matter, to senior citizens and those with significant comorbidities, regardless of race, especially if the multiple regression analysis proves my opinion? Dr. Woodcock?
What FDA did was to recommend that people at high risk would be candidates for these products.
Did you do a multi-regression analysis on this independent factor?
We did not.
Okay.
We did not. We don't make those kind of recommendations. We make.
But you can do studies, right? The FDA and CDC can do studies to see if it's truly an independent factor, or if not, truly the issue should be about your comorbidities and your age. So, Dr. Fauci, according to Forbes, you have an annual salary in 2020 was $434,000. You oversee over $5 billion in federal research grants. As the highest paid employee in the entire federal government, yes or no, would you be willing to submit to Congress and the public a financial disclosure that includes your past and current investments? After all, your colleague, Dr. Walensky, and every member of Congress submits a financial disclosure that includes their investments.
I don't understand why you're asking me that question. My financial disclosure is public knowledge and has been so for the last 37 years or so, 35 years that I've been director.
The big tech giants are doing an incredible job of keeping it from being public. We'll continue to look for it. Where would we find it?
All you have to do is ask for it. You're so misinformed, it's extraordinary.
Why am
All you have to
I
do is ask for it.
misinformed? This is a huge issue. Wouldn't you agree with me that you see things before members of Congress would see them, so that there's an air of appearance that maybe some shenanigans are going on? I don't think I assume that's
Senator,
not the case.
what
I assume
are you talking
it's not
about?
the case.
My financial disclosures are public knowledge and have been so. You are getting amazingly wrong information.
So
What are
I
you
cannot
talking
find them.
about?
Our office cannot find them. Where would they be if they're public knowledge? Where?
It is totally accessible to you if you want it.
For the public. Is it accessible to the public?
To the public.
Great. We look
Senator
forward to
You are
reviewing it.
totally incorrect.
Well, we
Senator
look forward to
Marshall,
reviewing it.
Senator Marshall, Dr. Fauci has answered you. It is public information, and he's happy to give it to you if you would ask. Senator Moran.
Chairwoman, thank you. I know this has been talked about. I've watched a bit of the hearing from my office this morning and into this afternoon, but would you highlight for me, I suppose this is for Dr. Woodcock, lots of funding, I think adequate funding, certainly knowledge about winter months would bring an increase in cases. What's the challenge in not being better prepared for access to testing in-home and elsewhere? And how soon will that change?
I don't think that's, I think that's a question for Assistant Secretary McConnell. But I would tell you, FDA has approved or authorized over 400 tests or collection systems just for COVID. We've authorized 15 over-the-counter tests, but it's capacity that we're talking about here, production capacity.
So there's no, what you were telling me, Dr. Woodcock, is there's no problem with the FDA approval of tests. It's the manufacturing process and the supply chain.
We could do more with more resources. We have authorized over 2,000 different device products, including the 400 test-related products in 2 years. So that's an incredible increase in the workload, and we really appreciate the funding that Congress has provided. However, the test manufacturers, many of them give us incomplete results. We have to go back and forth with them. The ITAP program that we are doing with NIH for home testing, I think will improve that tremendously. That's a big advance forward. But there's also the matter of production capacity with this huge surge and so many more people becoming infected.
Is there a separate FDA results process in which the test is read and determined positive or negative? There's no challenges there in that process?
That's what the ITAP program over at NIH is doing. They're actually doing the laboratory and clinical testing for the manufacturers, and then they send us the data. And so it's standardized and it's a panel, and that is really accelerates our ability to get these authorized very quickly. As I said earlier, we've authorized them within 2 days of getting the data from the ITAP program. So as that's a tremendous setup that I think is really beneficial, where we have standardized testing by scientists in the government, and that enables the manufacturers to get their products through very fast.
Thank you. Ms. O'Connell?
Thank you, Senator. And just to pick up where Dr. Woodcock left off, once those tests are authorized, ASPR reaches out to the manufacturers to make sure that we're optimizing the manufacturing capability. So that part is sort of a seamless process that we have. But all of the work we're doing in testing in this administration is in service of 4 priorities. 1, to expand the number of testing sites that are available. 2, to expand the number of tests that are available. That's the part that I'm working on to increase capacity. 3, the kinds of tests that are available. That's the part Dr. Woodcock just discussed. And then to help lower the cost of tests.
And is there a problem? I don't know whether the testing devices are manufactured domestically. do we have another challenge of the importation of tests, as we did with masks and gowns and gloves?
We continue to look for tests wherever we can find them. And we have encouraged, actually, some test manufacturers that are approved in Europe to apply for FDA approval here in the United States. So I do anticipate we will have some importation of tests at some point. But we've used the Defense Production Act authorities 12 times to support the domestic manufacture of tests and to priority rate those orders so we can increase the supplies and manufacturing capacity here in the U.S.
In the third of a minute that I have left, we've changed, I think, our view on masks recently, and we're emphasizing N95s. Is there any intentions to, is there a plan to manufacture additional 95 masks so they're more available? Is there a way to make them more comfortable? I'll leave that, that's the crux to my question.
We continue to support the manufacture of N95 masks. We have $737 million in the Strategic National Stockpile, all sourced from 12 domestic manufacturers. So we're continuing to support that. We are also in the process of putting out an agreement for warm base manufacturing. So we're able to keep this capacity that we currently have going, even when demand diminishes. So that's all underway right now. As far as fit and style and how they work, I'm sure colleagues at the table are probably have various pieces of their programs that might be participating to that effort and consulting with the manufacturers on how that will work.
Thank you.
Thank you.
Move to Senator Tuberville.
Thank you very much. Just very quickly, I know there's plenty of misinformation on both sides, when it comes to COVID, but I would say this, the fear-mongering on the left is, and I'm going to give you a couple of questions here about this, has made the matter as much worse. Dr. Fauci, I just want to ask you this for my constituents back in Alabama. Ivermectin, 40-year drug. Now, my constituents read this. They hear about it and all this. 40-year drug. They call it a wonder drug. It's about a nickel a tablet. It's done wonders supposedly in India and several other places. And then you have this new antiviral pill that we're coming out. And my constituents saying, this thing's going to cost $500, $600, $700 each. Could you give me a rundown on between the difference in those two, what you think about them? Get it on record here so I can tell my people back home, this is what Dr. Fauci says.
Sure. So Paxlovid, the drug from Pfizer, has shown in a randomized placebo-controlled trial to be highly effective to the point of 89%, almost 90%.
What's it called?
Paxlovid.
Okay.
It's made by Pfizer. And has been shown in a very well-controlled randomized placebo-controlled trial that if you take that drug compared to the placebo within the first 3 to 5 days, within the first 3 days, you have about an 89% chance of preventing you from going to the hospital or dying. There were no deaths in the Paxlovid group, and there were several deaths in the placebo group. That's Paxlovid. Ivermectin has had non-controlled trials suggesting that it might be effective, mostly anecdotal. The CDC, the NIH guidelines panel have looked at that data and felt there's not sufficient evidence to say that it works or it doesn't. The WHO recommends strongly against it and suggests that it might actually be harmful. The NIH active studies are doing a whole bunch of studies with ivermectin as well as others to try and settle it once and for all to prevent people from taking it if it doesn't work, because it could be toxic. So there's a world of difference between ivermectin and Paxlovid.
But this is a 40-year drug, and we're talking about one that's just now coming on the market. So we actually know that much about this Pfizer drug. I wish they'd come up with a lot easier names for their drugs.
Yeah, they always do that. They fool me too with the names, Coach, but it is what it is. The fact is, I think it's kind of a miscomparison to say one is a 40-year drug and one is a drug that was just discovered. It was just discovered, but it was shown in a very well-controlled clinical trial to be highly effective. Even though ivermectin is a good drug for some parasites, It has not been shown in a well-controlled, placebo-controlled trial to be effective in COVID.
Okay, thank you. Dr. Walensky, I don't know if anybody's asked this question. I just want to get cleared up. Our Supreme Court Justice last week, looking into the situation with the mandate, Justice Omar said there's 100,000 children that are sick as we speak with Omicron, and a lot of them are serious in hospital. Is that true or false?
I don't have the number of children in the hospital right now. It's likely less than 100,000.
Yeah, and Justice Breyer said that, that if we continue to delay this ruling, that we're going to have 750,000 more that are not vaccinated infected a day. I mean, does that make sense to you?
What I can tell you is our children between the ages of 0 and 4 are one of the only places where our hospitalization rates are currently rising, and that children who are in the hospital are generally unvaccinated, not uniformly, but generally unvaccinated. And that's true for not just our 0 to 4 who are obviously ineligible, but also true for our 5 to 11-year-olds as well as our 12 to 17-year-olds.
Thank you. Well, thank you all for being here today. Thank you very much. Thank you, Madam Chair.
Thank you so much. I have one final question for Ms. O'Connell and Dr. Walensky, and that's regarding education. In the past, we have seen school districts that serve a significant number of students of color or those in low-income or rural areas that are facing great challenges in accessing resources they need to serve our students. How is the federal government working now to make sure that states are equitably distributing tests and necessary resources like masks to all school districts, particularly those that serve predominantly students from families with low income, students of color, or rural students? And Ms. O'Connell, I'll start with you.
Thank you, Chair Murray. Equity is woven into all of the work that we're doing in this response. It's something that we remain focused on, including making sure that schools across all states are able to access the tools and resources they need. We gave $10 billion, as you know, from the American Rescue Plan for schools to be able to set up their funding programs. We're also testing programs. We've also made it possible through Operation Expanded Testing, which Dr. Walensky can talk more about, where we have regional hubs where schools can contract directly with labs to run their programs for them. That was designed for schools that might not otherwise have resources to be able to manage a testing program on their own. In addition, we're making tests available through the federally qualified health centers and rural health centers, and we've done that with masks as well earlier in the year.
Thank you. Dr. Walensky?
Yeah, and maybe I'll just pick up exactly where Asper O'Connell has put down. So, our ICAP program, our Increased Community Access to Testing program, does place tests in pharmacies and social vulnerability indices that are high. That's by design. Tests in federally qualified healthcare centers and community centers, just as the Assistant Secretary mentioned. We also continue to support screening tests at no cost to child care centers, K-12 schools, and congregate settings through exactly the program that the Asper mentioned, Operation Expanded Testing. We prioritize high schools that have, and all schools that have high social vulnerability, and we have a website now that's active where you can enroll.
Okay, thank you. Senator Burr, I understand you have two additional
Couple
questions.
of questions, if I could, Madam Chair. This is for Dr. Woodcock and Ms. O'Connell. It's my understanding that prior to Omicron, Barta informed some therapeutic manufacturers that they would no longer be supporting additional work on new therapies because there's no longer an unmet need, which may impact whether and how FDA prioritizes reviewing such therapies. Did Barta and FDA change course on this policy once the Omicron variant was discovered in November?
Barta's decision to put that notification out was in light of the fact that the therapeutics development was moved over to Operation Warp Speed, and Barta was supporting the therapies that were being developed through the Warp Speed effort. So it was a way of combining the funding that was available to be able to move the therapies through faster. Barta never stopped supporting therapy work, but I'll let Dr. Woodcock.
Yeah, there is, we still regard there is an extreme unmet medical need for therapeutics at most stages of the disease, particularly the late stages where we still don't have interventions, and so people are dying in the late stage of disease, getting into the ICU, going on the ventilator. So of course, we have 670 INDs that we've been, clinical protocols that are ongoing, to my knowledge. So the robust development is still ongoing in the therapeutic area.
So how much funding has Barta allocated to therapeutics this year, and how much is left to spend?
I'll have to go back and check that on the actual development. We've spent a lot of funds this year on the procurement of the therapeutics that have already been developed, but be more than happy to bring that number to you and your staff.
And I'm talking about the development end of it. Because there's a firm belief out there that Barta went to the industry and said, we're not supporting this anymore. They didn't say this got moved over to Operation Warp Speed, which, by the way, doesn't exist anymore. But they said, Barta said, we're not supporting therapeutics because there's not an unmet need. That's what the industry heard. I'd love for you to clarify that for me. Last thing, Dr. Woodcock, since we did discuss the point of care and at-home testing, I just happened to come up with a chart that FDA put out not long ago. So let me just, and you're probably familiar with it. One's molecular, one's antigen, and one's serology. And for the molecular and the antigen, if you test yes for point of care or at home, that kicks you to the right. The next box is high manufacturing capacity. If your answer is no there, it kicks you down to an FDA intends to decline box. There's no option. So if you're not a high manufacturing test, then FDA is going to decline to review. Boy, I got to tell you, I think this is a huge mistake. Now, if you tell me that you've got a couple hundred tests that fall into the high manufacturing capacity right now at the FDA, where you've got the luxury of being able to kick out new innovative companies that haven't solved their manufacturing yet, by all means, tell me that's the case, that there are a couple hundred. Right now, Ms. O'Connell's struggling to buy 500 million tests. We're 47, maybe 50 million there. That leaves another 450 million to purchase. And we're going to distributors trying to buy their inventory, not to manufacturers trying to buy their capacity. Something's not right here, guys, on testing. And I will tell you, the current administration's chief of staff got it right in 2020, March, and he said, testing's broken, testing's broken, testing's broken. I just say to all of you right now, testing's broken. And Ms. O'Connell, I think the responsibility falls to the ASPR. I wrote the law. If, in the case of CDC, they were the delay to begin with, but to acquire testing, that falls in your lane. And I, for the life of me, can't figure out after $82 billion, except for somebody sitting down and saying, well, we just don't need those tests. We don't need to buy them. How you could let Abbott close 2 lines because there wasn't any business. These are some of the most premier manufacturers in the world that we've let get out of the mass manufacturing of home test business. If I'm wrong, tell me I am. I respect all 4 of you in a huge way. But I also express my disapproval very quickly, and that's what I'm doing today. Anything you want to add to that, Ms. O'Connell?
Please, thank you, Ranking Member Burr. Let me just clarify, of course, that the initial contracts you're speaking of towards the $500 million were the available inventory that these distributors had. These are the distributor contracts. The manufacturer contracts are currently being worked. You will see that capacity come on quickly. We just haven't been able to land the contracts, to draft the contracts as quickly as the distributors, but they are coming.
My suggestion in the future is that when you guys huddle inside the COVID team, try to get the administration to refrain from making these proclamations until we've got the product, until we know who we're negotiating with. We're now 3 weeks since the president said we're going to buy 500 million tests. We have 50 million currently contracted. I don't know how long it's going to take to get the rest of the contracts. This is not dissimilar to when we went out and said we're going to booster everybody in America, yet we rolled it out with just people over 60 to start with, and then we started moving down. And now we're begging people to get boosted, which is where we should have been on day one because we had the product available. But listen, you guys have a tough job. And I don't know of anything else Congress can do than try to create the statutory framework that you can work in to do your job, which exists, or provide the funding to allow you to acquire. Those are the only two things we can do other than bitch and gripe when it doesn't happen as quickly as we'd like. But Tony, I really respect you, and I'm sorry you and your family are going through what you're going through. But please understand, we go through that every time we go home with millions of people in North Carolina, millions that believe the bad information that's out there, millions of people that have a loved one in the hospital, but there's no monoclonals for them to take, millions of people who are unvaccinated, probably wish today they had gotten vaccinated, probably wish they had gotten boosted, but they're now in the ICU and their wife or husband or daughter is calling us and saying, what do I do? So we're here to support. What you need, tell us. But don't think that we're just going to sit here and print money without a full accountability of where it has gone. And I hope the secretary is listening to that conversation today. Senator Blunt and I said, give us a full audited accounting of the $82 billion and we'll entertain additional funding for testing. That was 10 days ago. I'm not sure when we're going to get it or if we're going to get it, but it's conditional. And this is the most powerful person on the other side of the appropriations.